Thank you and good morning. The good news is that I don't have any photos of genitalia. The bad news is that I don't have any photos of Pamela Anderson. I want to thank the organizers of the meeting for inviting me to come and speak about emerging and reappreciated sexually transmitted infections. I have no disclosures. So the WHO lists over 30 infectious agents that have a component of sexual transmission. Some of these are the bread and butter STDs that most of us are familiar with, like syphilis and gonorrhea, where the primary mode of transmission is sexual. However, there are a number of other pathogens that have a component of sexual transmission while their primary mode is not sexual. Understanding the sexual transmission of these pathogens can help inform prevention and control programs, as well as populations that may need additional targeting, for example, men who have sex with men or pregnant women. So I only have 20 minutes and there's a lot to talk about. So rather than going deep, I went wide. So I'm going to give you an amuse-bouche of 4 different sexually transmitted pathogens that we don't hear very much about. I could talk for an hour on each of these, so there's certain aspects that I won't cover. In the emerging realm, I'm going to be talking about Ebola virus and the Zika virus, and then in the reappreciated STIs, I'll be talking about Neisseria meningitidis and Shigella. So I'll begin with Ebola. The 2015 Ebola epidemic that focused in West Africa was the largest on record. Prior epidemics had been small and isolated in East Africa, but the epidemic that began in 2015 impacted almost 29,000 people with over 11,000 deaths. It had always been hypothesized that there was a sexual transmissible component to Ebola, particularly given the immunocompartmentalization of the male testes. However, before the 2015 epidemic, there was really limited data on this. The smaller clusters that had occurred in East Africa, for those persons that survived, there were small case series that were conducted to try and get specimens to look at ongoing shedding of virus post-survival. Each of these rows in this graph represents a person, and this Christie article is actually from the 2015 epidemic, but you can see that in some of these earlier epidemics that there were males who had positive semen specimens 63 days up to 97 days after release from the Ebola treatment units. The response to Ebola was largely focused on containment and contact tracing, and when folks began to ask questions about sexual transmission, it was considered not a top priority at the time. And then in 2015 in Liberia, there was the first confirmed case of sexual transmission. Prior to this, there had been anecdotal evidence of male survivors of Ebola infecting their females or, to a lesser extent, male partners. However, we were never able to confirm this until the Liberia case. So in this scenario, patient A was a female who was married to a male survivor of Ebola who was infected with Ebola and lived in an area where there had not been active transmission. The male partner was the only known exposure to Ebola, and subsequently, after genotypic testing, it was confirmed that the female Ebola case and her male surviving husband had the same genotypic type of Ebola. This suggested that Ebola was in fact sexually transmissible and that there was actions that needed to be taken. So as you can imagine, this instigated a lot of flurry of activity. And I'm going to focus just on one component, which was risk reduction counseling and messaging. We had a lot of experience with HIV post-test counseling and messages around safer sex with respect to HIV. But we quickly learned that Ebola was quite different. With HIV, something like mutual masturbation is considered a safer sex practice, but we weren't sure with Ebola if getting semen on your skin was a risk factor for subsequent infection. So materials needed to be made and distributed in a culturally competent capacity. This is one of my favorite artifacts from the Ebola response, and I want to thank Dr. Mary Choi, who's with the Viral Special Pathogens Group. So this was created in Liberia, and this was part of the Liberian Men's Sexual Health Program. So in order to instruct males how to collect a semen specimen, they created a fact sheet here It was very difficult to find translators of English to Liberian English, and the folks that they found were actual missionaries who were there translating Bibles, and I would have loved to have been involved in the conversations. So just to give you a sense, ejaculation in Liberian English is how to get the water that comes from doing man-woman business. So man-woman business is sex, and water come down is ejaculation. So just to give you a sense, going into a country that does not have a strong sexual health infrastructure, has very little sorry, it's really early, availability of sexual health translation. This was quite a challenge to get culturally competent material. Liberia, Sierra Leone, and Guinea were the three most impacted countries, and all three eventually developed semen testing programs. And this is a summary of the results from SOCA, which was published in Lancet Global Health. I'll quickly walk you through these slides. These days on the left side represent the number of days since release from the Ebola treatment unit. MSHP is the Liberian Men's Sexual Health Program. Sierra Leone was the viral persistence study, and then Guinea began a project soon after. There were a small number of males who were followed in the United States. But as you can see, between 181 and 270 days post-release from the Ebola treatment unit, in Liberia, 22% of males were still RT-PCR positive for Ebola, and 26% in Sierra Leone were still RT-PCR positive. It's important to note that it's not necessarily infectious agent that's being found. This is a PCR test. Viral culture is needed, but I would suggest that it's likely that there were infectious agent at some point post-release, because it's unlikely that someone would be shedding genetic material 270 days after clearance of the virus. So while the aspects of sexual transmission haven't been fully quantified, it did not likely have a huge impact in the epidemic spread of the infection. In the West African outbreak alone, there were approximately 5,000 male Ebola virus disease survivors. So what this means is that while it probably didn't instigate the large spread outbreak, there is the risk that these Ebola virus disease survivors could establish new clusters or flare-ups in communities either already impacted or in areas that were naive and had not set up infrastructure to respond quickly and effectively to Ebola. I'm going to switch now and speak about Zika virus and focus pretty much exclusively in the United States. So between January 1st, 2015 and August 9th of 2017, there were 5,400 Zika virus cases reported in the United States. And as you can see, while the majority of them were travel-associated cases, there were 47 cases that were attributed to sexual transmission. In the U.S. territories, there were over 37,000 Zika cases, with the bulk of those being locally acquired as well. Sexual transmission of Zika had also been presumed as possible. It was suggested by at least 2 reports before the current outbreak in the Americas, one from 2008, which suggested sexual transmission after a visit to Senegal, and then secondly, after recovering Zika virus by culture and RT-PCR in the semen of a symptomatically infected Tahitian man in 2013. In early 2016, similar to Ebola, multiple case reports of sexual transmission were coming in to various agencies, and a number from travelers returning from areas with active Zika transmission and infecting partners who had never traveled to Zika endemic areas. This slide is a little bit old, but at the time, it was there were at least 13 countries, including the United States, that had a report of a sexually transmitted Zika case. So these data are a little bit stale, but I will let you know that in the next day or two, there is a paper coming out in PLOS Medicine by Michel Conote and I butchered his name, and Nicola Lowe's group on an living review of sexual transmission of Zika that will be updating all of these parameter estimates. But to give you a sense, for males, after symptom onset, there's been an estimate of 69 days where there's culture-positive Zika. observed sexual transmission occurring 32 to 42 days after symptom onset, and RT-PCR positive semen specimens up to 188 days following symptom onset. So again, these are sparse data. There's very small studies and case reports, but this does suggest that there is the potential for an ongoing transmission of Zika among males who had cleared their infection. For females, it's a little bit of a different story. For female cases, there's been reports of culture positivity for women just 3 days after symptom onset. There's been no observed sexual transmission, and the period where RT-PCR positive specimens coming from cervical vaginal swabs is much shorter, with a range of 14 to 11 days. Similar to Ebola, there needed to be a lot of health communication and messaging materials developed with respect to Zika to make sure that we were providing adequate and scientifically valid recommendations. So this is an example of some of the materials that CDC had put together. Zika can be passed through sex from a person who has Zika to his or her sex partners, and this includes vaginal, anal, and oral sex, as well as the sharing of sex toys. Zika can be passed through sex even if the infected person does not have symptoms at the time. It can be passed from a person with Zika before their symptoms start, while they have symptoms, and after the symptoms end. And the virus may also be passed by persons who never had symptoms. Next, I'm going to speak about Neisseria meningitidis. Neisseria meningitidis is a bacterium that is a cousin of our favorite Neisseria gonorrhea and is often implicated in the development of invasive meningococcal disease, which is a severe consequence of infection. It's transmitted through droplet, although it has been isolated from the male urethra. This is one of my favorite studies. In 1972, it was determined that a male chimp had auto-inoculated himself with Neisseria meningitidis in their throat after having a urethral infection. I'm not sure how they determined this. I guess there's cameras in the monkey cages. But there's been some sporadic reports of dyads and clusters of meningococcal urethritis that's showing that it can be epidemiologically linked among sex partners. Recently, in the United States, Europe, and Canada, there have been outbreaks of invasive meningococcal disease identified among populations of men who have sex with men. It's suspected that droplet transmission within these MSM networks could explain these consistently higher rates of Neisseria meningitidis nasopharyngeal carriage rates relative to heterosexual men. In the late 2000s or late 2010s, there was an invasive meningococcal disease outbreak in New York City among men who have sex with men. Here you can see an epidemic curve. 22 cases were identified during this outbreak period, which the response included a vaccination and outreach campaign. This is a poster that was put up around New York City in areas where high-risk MSM may congregate. And in an MMWR, that summarized several outbreaks among MSM in 2012 to 2015, you can see here, So the outbreak in New York City, there were 23 MSM. In Los Angeles County, 14. In Chicago, there were 11. And in other cities, which included the jurisdictions listed below, another 26, 74 total MSM-associated meningococcal disease cases. I think what's important to consider is that almost all of these were subtype C, which is quite different than what we tend to see in our more bread-and-butter meningococcal disease outbreaks, which occur on college campuses or in military installations. So this has implications for follow-up and immunization programs as a preventative measure for these populations. Additionally, this was referred to a little bit yesterday. I'm going to switch gears a little bit, but late last year, there was a paper that came out from the group in New Zealand that largely uses the meningococcal B vaccine, and they produced a study that showed that men or people who were vaccinated with the meningococcal B vaccine seemed to have a lower risk of getting genital gonorrhea, which was quite exciting because we're quite interested in a vaccine for gonorrhea, but we haven't been terribly successful. So this suggests that there may be something we could learn from Neisseria meningitidis that could inform prevention and control programs for Neisseria gonorrhea. Finally, I'm going to talk a bit about Shigella. Shigella is a diarrheal disease that's caused by the bacterium Shigella. It's transmitted by direct or indirect contact with human feces. Typically, we see highest rates of Shigella among children under the age of 5, their caretakers, and travelers. Transmission, however, can occur through oral anal contact or digital anal sex. In the 70s and 80s, there were increases noted among males in the United States, even as overall rates and rates among children declined. And in the UK, between 2004 and 2015, there was a large increase seen among Shigella among males, and it was suggested by the male-to-female ratio that this was an MSM-driven epidemic. Furthermore, strains of Shigella that circulate among MSM populations have been showing increasing rates of drug resistance. So this is some historic data back in the 1960s and 70s. On the left side, you can see that it's somewhat hard, but this represents the male rate. All the others are the female and male rates for Shigella. What we note here is that the rate among males 20 to 29 through 40 to 49 is much higher than what we see for females. And this was an indication early on that this was perhaps an MSM-driven, there was an overlapping epidemic with MSM. If we look over here, we see between the 80s, in 1981 through 1985, large increases in Shigella flexneri among males as well as soni among males, again suggesting a disproportionate burden among male populations. More recent data suggests there continues to be an excess risk among males. In data from 2004 through 2015, we see that the flexneri rate or the count is significantly higher than what we see for females. And again, when we look at 2004 through 2014 over here, we see that the rates are disproportionate among males as well. Furthermore, among a population of cases among MSM with drug resistance, there is a suggestion that there is some travel that may be implicated and could be transmitting drug-resistant Shigella throughout the globe. So this graph represents the epidemic curve of a number of Shigella cases that were reported, 239 between 2014 and 2015. The black bars represent cases that had traveled to Central and South America. These blue bars represent India. The other colors represent other states. And then there was this large outbreak, which was in San Francisco. So there's a suggestion that there is a travel-associated component, there's a sexually transmitted component, and there may be an increased risk of drug-resistant Shigella. In response, there's again been public health messaging. The poster on the left is from the Public Health England, which I think is a great poster. And if you've gone to London, you've probably seen these in men's, if you're a man, you've probably seen these in men's bathrooms. If you're a woman, I'll tell you they're in the men's bathrooms. And then on the right is a fact sheet that was produced from the CDC. So to summarize, there are many infections that have a sexual component of transmission. While they may not be primarily sexually transmitted, they may be important in terms of understanding the epidemiology, risk factors, and populations at risk. And I encourage STD clinical and research practitioners to contribute to these, to response to these agents, because there's a big need for the development of prevention messages, control strategies that are culturally competent and include scientifically valid information about sex. What I've learned is that, at least at CDC, when anything involves sex or MSM is involved, they come running to the STD division because people are pretty uncomfortable talking about sex. So as STD practitioners, we have a responsibility to help others in the public health field when there's a potential sexually transmitted component. Additionally, identification of important epidemiologic data is important during case investigations. Again, the folks in diarrheal diseases or Ebola are not comfortable asking about receptive anal sex partners or rimming or sharing of sex toys, so it's our responsibility as STD folks to encourage that. The asking of the questions, not the practices. And then finally, establishment of standardized criteria for determining if a pathogen is sexually transmitted is something that would be valuable to the field. And that's it. I'm happy to take any questions.
Thank you.